Hello everybody, I'm Matthias Ort from Vincent von Paul Clinic in Stuttgart and Heidelberg University, and today we are talking about the current status of detecting monoclonal antibodies and free light chains in serum. Our concern is the diagnosis of multiple myeloma, and there are different classifications, and there have been some changes in the last years. So I will first start with an introduction to multiple myeloma and the related diseases. We all know the famous MGUS, the monoclonal gammopathy of unknown significance. It's a benign disease which rarely involves into multiple myeloma. We have a negative M gradient. We have very low number of plasma cells in bone marrow, and there are no other signs of multiple myeloma in serum, such as abnormal calcium values. We have a normal renal function. We have no anemia, and there are no bone lesions. Then we have the full diagnosis of multiple myeloma. It's a symptomatic disease which requires treatment, and the characteristics are this CREP. This is hypercalcemia. It's a creatinine clearance lower than normal. These are bone lesions visible on bone radiography or CT or PET scan. We have an anemia, and there is a high proportion of plasma cells. And a patient like this is shown on the right-hand side, and everybody can see that there are numerous bone lesions, and it's clear that this patient will also suffer from this high calcium in his serum, which damages also the kidneys. In these patients with multiple myeloma, we have a higher proportion of one of the three serum light chains also. And then there's a big challenge. We have many patients which are just between MGUS and multiple myeloma, and it's called smoldering multiple myeloma. It's pathological, and it will progress into multiple myeloma at a rather high rate. And these are the patients where we are not very sure how to proceed. We have the treatments in MGUS, which is in essentially all cases not a reason to treat. It's only watch and wait. And in myeloma, there's no question that this is a disease which has to be treated rather aggressively. And for the patients between the smoldering myeloma, there are some where we do watch and wait, and others where we start treatment. And the new treatments in multiple myeloma are the reason why this diseases came into our focus. Few decades ago, there were only very few treatment alternatives for multiple myeloma, such as steroids in the first-hand side and some rather unspecific chemotherapy. And in the last years, quite a few very positive and very aggressive, on one hand side, means eliminating the myeloma cells and not so much damaging the patient's treatments were developed. Many of them employ monoclonal antibodies, bortezomib and daratumumab, a monoclonal antibody. We have the disease as a progress from MGUS over to smoldering myeloma into active myeloma, and we hope that the treatment we can offer to the patient will keep the patient on a relapse for rather, a remission for a rather long time. The treatments are rather complicated and rather costly, and so it's very important to detect the patients who need the treatment, and for the patients under treatment, it's very important to monitor the progress or the regress of the disease. And now the complications arise. When we are talking about multiple myeloma, we have patients which produce in their abnormal cells intact immunoglobulins and free light chains. This is majority in about 3/4 of the patients. We have some patients who secrete only intact immunoglobulins, is about 10%. About 15% of the patients only secrete free light chains, and there are very few patients who do not secrete any abnormal plasma proteins. And this is the challenge when we use either immunoglobulins or free light chains for the detection of the disease. So we know that the way we use, whether we look for free light chains, will not detect some patients, and we use only for intact immunoglobulins, we also will have a diagnosis failure in a few patients. So our topic today is the detection of multiple myeloma by free light chains assays, and when we employ this strategy, we will detect about 90% of the patients with multiple myeloma. What are the methods to detect free light chains or monoclonal antibodies in these patients? The oldest technique is the serum protein electrophoresis, and we are looking for this M gradient, monoclonal gradient. Then we can do some immunofixation, or the newer techniques is doing immunotyping in the capillary electrophoresis from serum. Some people also do it from urine, and we'll come to this later on. Then traditionally there's done some quantification of immunoglobulins, such as IgG, IgA, and IgM in serum. And there's also in the focus in the last year the quantification of the free kappas and the free lambda light chains in serum, and very important, the calculation of the ratio between these both free light chains. What are the techniques we are employing? For serum protein electrophoresis, you all know this looks like a normal protein, serum protein electrophoresis, and when we get the patients with multiple myeloma, we have either an abnormal fraction or peak exogradient. This might also be an asymmetrical fraction. It might be a very high fraction, and such in these patients, I might call this like a typical high fraction with a co-migration. And there also can be a very low gamma globulin fraction if only monoclonal free light chains are present in this patient. Overall, the sensitivity of this technique is rather low. For the quantification of the monoclonal antibodies, one quantifies the M gradient, and this is also a rather raw method, and it only works when the patient also secretes immunoglobulins. If we have a patient who only secretes free light chains, it will fail, and so serum protein electrophoresis is not a method to detect the progression or regression of the disease. In immunofixation, the proteins from serum or from urine, such as Jones proteins, separated in the electric field. They're detected by specific antibodies, and the separation is done either by G electrophoresis or capillary zone electrophoresis. And this shows an example of a normal sample, as you know it. In the first line, it shows the normal serum electrophoresis, and then we have a rather unspecific polyclonal IgG, IgA, IgM, and kappa and lambda. And on the right-hand side, you will see a patient with monoclonal banding in IgG and in kappa, so it's a monoclonal IgG kappa. The challenge of immunofixation or immunotyping is that it's in some cases it's black and white, but in many cases we get some results which are not so clear, and getting the diagnosis of a monoclonal IgG kappa or IgG lambda to a patient will change the life of this patient. So we have to be very sure that the diagnosis is rather reliable. And it's very time-consuming in the lab, because we have to discuss about the results of this testing. Then also we do the quantification of the immunoglobulins. This is traditionally done by nephelometry, or nowadays by tubidimetry. And in patients with multiple myeloma, they will either have an increase of the involved immunoglobulins, in particular with IgG, and they might also have a decrease of the non-involved immunoglobulins when there's when the abnormal plasma cells override all the other cells in the bone marrow. But this is also rather gross estimation of the tumor. Now it comes to the detection of free kappa and free lambda light chains. So the plasma cells either produce free kappa chains or lambda chains, and they have a rather complicated metabolism. So the production rate of kappa to lambda is about 2:1, but the kappas are monomeric and the lambdas are dimeric. So the filtration by the kidneys of the monomeric kappas is larger than of the dimeric lambdas, and so actually the resulting blood concentration is 1:2. It's just the opposite way. But you also can see that the kidney function will will influence the concentration of kappa and lambda in the blood. And we also have seen that myeloma will lead to renal insufficiencies. So it's pretty tough to tell whether somebody got a bad kidney function because of myeloma, or he just has abnormal ratio of kappa and lambda because of his renal function deficiency. The reference range is an indicator for clonality. So if there is a normal production of free kappa and free lambda chains, the reference range of this ratio is about 0.37 to 1.4. And in patients with renal insufficiency, the kappa ratio is a bit higher, about 0.46 to 2.23. But this is rather a challenge because renal insufficiency is not black and white. There are people with a severe impaired renal function, and there are many people with slightly impaired renal function. And when we employ different reference ranges, it's complicated to tell, shall I start with a GFR below 60 to use this renal insufficiency ratio, or shall I start with 40 or 45 or 35 and so on? Rather challenging. So, for example, if a patient either got kappa lambda ratio highly elevated with 8 or very low one with 0.6, they got either monoclonal kappas in this elevated case or monoclonal lambda in this severely diminished ratio. The